Stop using cotton swabs in your ears. That little habit you think is cleaning you out may be pushing fibers and wax deeper, compacting material against your eardrum, and in some cases contributing to pressure, muffled hearing, or ringing that won't go away. Before we go any further, this is general information, not medical advice. If you have severe ear pain, bleeding, discharge, sudden hearing loss, or persistent or worsening tinnitus, see an ENT specialist or your primary care provider right away. Clinicians and audiologists warn that the ear is delicate. What feels like a simple fix can sometimes make things worse. If you want a practical checklist of safer steps to replace the cotton swab habit, download the ear safety checklist linked below and keep it handy while you try the 7-day reset I'll walk you through. If you've ever dug at a ditch in your ear with a swab, you're not alone. Reaching inside feels like immediate relief. The problem is that relief is almost always short-lived, because the ear isn't a dry, empty tube waiting to be cleaned. It's an ecosystem. To understand why those tiny cotton tips can hurt more than help, we need a quick primer on how your ear normally works. Earwax, or cerumen, is not dirt. It's a mixture of oils, dead skin cells, and sweat from glands in the ear canal. It has a job. It traps dust, bacteria, and tiny insects. It keeps the skin of the canal lubricated, and it even has mild antibacterial properties. Think of it as a natural filter and moisturizer. The ear canal is also slightly self-cleaning. Tiny hairs and jaw movements, chewing, talking, yawning, gradually move older wax out toward the outer ear, where it flakes off or is washed away when you shower. When that system works, you rarely need to touch the inside of your ear. But when you introduce a cotton swab, that system gets disrupted. A swab tends to push wax inward rather than pull it out. The cotton tip can unravel or leave fibers behind. Those fibers catch on wax, skin flakes, and oily debris, and over time can act like a skein that draws material deeper and compacts it. What started as a small soft mass can become firmer and more adherent to the canal or the eardrum. Compacted earwax can produce several symptoms. You might feel fullness, pressure, or muffled hearing. You may even notice sounds seem distant or dull. For some people, compaction or pressure changes in the ear canal can trigger tinnitus, a ringing, buzzing, or hissing perceived in the absence of an external sound. It's important to be precise here. Tinnitus is complex and has many causes. Earwax impaction is one possible, sometimes reversible factor. In other cases, tinnitus comes from inner ear damage, loud noise exposure, certain medications, jaw problems, or stress. Still, if you have a history of frequent cotton swab use and you develop new fullness or ringing, impaction is a plausible place to start. How does the compacted material relate to the sensation of ringing?
There are a few plausible mechanical pathways. A lodged, firm plug can alter how sound is conducted into the middle and inner ear. That conductive mismatch can change the balance of incoming signals and lead your brain to interpret odd sensations as ringing. Additionally, pressure against the eardrum or narrowing of the canal can stimulate nerves in ways that might be perceived as sound. Finally, inflammation around impacted wax can subtly change the ear's local environment and may coincide with tinnitus. The key phrase is may or can. This is not a guaranteed cause and effect for everyone, but it is a recognized contributor in clinical reports. There's also a mechanical twist you should know about. Cotton fibers, when left behind, are not inert. They can entangle with cerumen, and because the canal is a narrow, curved space, the accumulated mass can become compressed over time. As it compacts, it can feel like a pebble or plug that doesn't move with normal jaw motion. Some people describe sharp pressure when they fly or dive, because the compressed material doesn't equalize easily with changing air pressures. In rarer situations, aggressive swabbing or forceful insertion of objects can damage the eardrum itself, creating perforations that require medical attention. Let me tell you about Maya, a composite vignette based on common clinical patterns. Maya had used cotton swabs for years. Every shower, every time she felt that tiny tickle, she'd reach for a swab to clean the ear. She liked the momentary sense of cleanliness. Over months, she noticed her left ear felt more full after swimming, and she had to turn up the volume on the TV. One morning, she woke to a persistent, high-pitched tone in that ear. She assumed it would fade. After a few weeks without improvement, she saw her primary care doctor, who referred her to an ENT. Examination showed a deep, compacted plug of wax with kindled cotton fibers adhered to it. The ENT removed the material professionally and gently, and Maya's hearing and sense of fullness improved substantially. The ringing diminished but did not vanish entirely. In Maya's case, compacted debris was a reversible contributor to her symptoms, but it wasn't the whole story of her tinnitus. That story highlights two important things. First, habitual swabbing can create the exact problem people are trying to avoid. Second, removing the plug may help, but tinnitus can have multiple layers. That's why professional evaluation matters when symptoms persist. So, what should you do instead of reaching for a swab? Start with 3 basic rules. Stop inserting anything into the ear canal, care for the outer ear gently, and protect your ears from loud noise and water intrusion that could complicate things. Stop inserting anything. Your finger, a towel corner, a cotton swab, an ear candle, a hairpin, none of these belong inside your ear canal. They can push material deeper, scratch the skin lining the canal, or...
Ear candles are particularly unsafe. They offer no proven benefit and carry risk of burns and wax pushed deeper into the ear. Care for the outer ear. After a shower or bath, gently dry the outer ear with a soft towel. Tilt your head to each side to allow water to drip out. You can dab the outside openings with a tissue if you feel wetness. Avoid aggressive scrubbing or digging. If your ear feels itchy on the outside, you can use a soft washcloth over your finger to clean only the visible outer area. Mind your earbuds and earphones. Frequent deep insertion of earbuds can contribute to pushing material deeper and may trap moisture. Use looser fitting or over-ear headphones when possible, and avoid pushing buds all the way in. Keep volumes at safe levels and take listening breaks, because noise exposure itself is a major cause of tinnitus and hearing loss. Consider conservative, non-invasive options if you have mild wax buildup that is not painful and you have no history of ear surgery, perforated eardrum, or active ear infection. Some clinicians recommend over-the-counter cerumen softening drops. These products are intended to soften hardened wax so it may come out more easily on its own. If you go this route, follow the product label and check with the clinician first if you've had prior ear problems. Do not try forceful home irrigation or syringing without being cleared by a healthcare professional. If done incorrectly, it can injure the eardrum or introduce infection. If you have kids, be even more cautious. The ear canals of children are smaller and more delicate. Parents should not insert cotton swabs into a child's ear. For visible outer ear debris, use a soft cloth. If a child complains of pain, reduced hearing, or persistent ear symptoms, see a pediatrician or ENT rather than attempting home removal. Now, let's translate this into a short, practical experiment you can try. A 7-day ear habit reset designed to break the automatic reach for the swab and replace it with safer, measurable behaviors. This reset is not medical treatment. It's a behavioral scaffold to help you reduce risk and gather evidence about whether your symptoms change. If anything gets worse, seek medical care. Before you begin, prepare a small pack. A soft towel, facial tissues, your symptom mini journal, paper or an app, just something simple, and a mirror. Download the ear safety checklist to keep beside you during these 7 days. The checklist will remind you of red flags and give easy prompts for each morning and evening. Day 1. Stop and anchor. The first action is simple and challenging. Do not insert any object into your ear canal for the entire day. Replace that moment of reach with an anchor habit. An anchor habit is a physical cue that triggers a safer behavior.
Choose something you already do daily, like washing your face or brushing your teeth, and pair it with an ear care step. After you shower, towel dry the outer ear and tilt your head to let any trapped water escape. If you feel the urge to probe, practice a 90-second interruption. Pause, place a hand over your mouth, breathe slowly, counting to 90, and then decide whether you still feel compelled to touch your ear. The 90-second pause is not magic, but it breaks the automaticity of the habit and gives your brain time to assess whether action is necessary. At the end of the day, make a quick journal entry. Did you pick at your ear? Rate your urge to pick on a scale of 0 to 10 and record any symptoms like fullness, ringing, or hearing clarity. Day 2. Identify triggers and adjust cues. Habits arise in context. Where do you tend to swab? After a shower, while lying in bed, or when you're half asleep watching a show? Spend today simply noticing. Carry tissues instead of swabs if you keep them in a bathroom or bedside table. Remove visible cotton swabs from common areas so the sight of them doesn't cue the action. When you feel the urge, use the same 90-second pause. Add an alternative microaction. Press a clean fingertip gently to the outer tragus, the small part of cartilage at the front of the ear opening, and massage gently for 5 seconds. This will not remove any internal wax, but it can give tactile feedback and a momentary sense of relief without inserting anything. Record your urges and any symptom changes. Day 3. Visualize and rehearse. Habits respond to rehearsal. Take 5 minutes to imagine a realistic scenario where you would normally reach for a swab. Visualize yourself noticing the urge, performing the 90-second pause, choosing the alternative microaction, towel drying or tragus massage, and then logging the experience. Mental rehearsal strengthens the new neural pathway. Practice this visualization once in the morning and once in the evening. Continue journaling. Note the number of urges, whether you resisted, and any changes to sensations of fullness or ringing. These first 3 days are about interruption and replacement, creating a short, repeatable ritual that prevents immediate harm. Many people underestimate how much repetition it takes to change an automatic motion, so be patient with yourself. If you slip, don't treat that as failure. Treat it as data. Note what triggered the slip and adjust your environment to remove that cue. Alongside the behavioral work, pay attention to easy protective steps you can use immediately. Lower headphone volumes, limit prolonged use of earbuds, and avoid banging your head or jarring movements that could disturb the ear. If you swim or shower, tilt your head to the side afterward and gently dab the outer ear dry. If you wear hearing aids or earplugs, keep them clean and avoid over-inserting them beyond manufacturer guidelines. At the end of day 3, check your journal.
Are you noticing any difference in hearing clarity or the intensity of ringing? For many people, 3 days won't be enough to shift physiological impaction, but it can reduce further compaction and prevent additional trauma. If you started this reset because of sudden pain or a new, intense ringing, stop the experiment and see an ENT immediately. Acute symptoms with pain or drainage are red flags. Day 4. Observe and nudge. Today, extend the practice of gentle outer ear care. If you bathe, make a point to dry your ears more deliberately. Tilt your head, use a towel to dry only the visible outer area, and then log any sensations. If you had been using earbuds, try at least 1 day with over-ear headphones or no devices at all to reduce pressure and moisture. Continue the 90-second interruption when the itch temptation appears. If you notice that the urge often follows certain activities, perhaps after earphones or during allergy season, consider whether other simple changes, like allergy management or keeping earbuds out for a day, might lower urges. If at any point you notice worsening pain, bleeding, discharge, or suddenly muffled hearing, seek medical evaluation. Don't wait to see if it resolves on its own. Likewise, if your tinnitus suddenly increases in loudness or becomes persistent despite the reset, that's a signal to consult an ENT or audiologist. Day 5. Gentle options and clinician checks. If your ear symptoms are mild and you have no history of eardrum perforation or ear surgery, you might think about cerumen softening drops discussed earlier. Remember, some clinicians recommend these products when impaction is suspected, but the decision should be individualized. If you opt to try OTC drops, read the instructions carefully and stop immediately if you feel sharp pain or have any discharge. Keep documenting symptoms. If you are unsure whether drops are safe for you, check with a clinician first. For many people, 5 days into the reset is when the mental and environmental habit changes begin to feel less effortful. You'll likely notice fewer automatic reaches and more awareness around the ear, but physiological removal of compacted wax, if it is present, usually requires professional tools. If you suspect an actual plug, persistent muffling, a sense of blockage, or a subjective decrease in hearing, consider scheduling an ENT appointment rather than attempting forceful home remedies. Day 6. Measure and reflect. Today is a good time to take a simple hearing check at home. Stand a few feet away from a family member or friend and have them speak at normal volume while you cup and then uncover your hand over your ear to compare sound clarity. That's not a diagnostic test, but it can help you sense changes. Continue the replacements and journaling. Note any improvements, no change, or worsening. This day is about collecting reliable observations rather than seeking immediate fixes. Day 7. Consolidate and plan. At the end of the week, look back at your logs. How many times did you reach for a swab? Has your urge score decreased? Has fullness or ringing changed at all? If you've had measurable improvement in symptoms and no red flags, keep the new habits going and consider extending the program to 30 days to consolidate change. If there's partial improvement, or if you still experience noticeable blockage, schedule an ENT visit. If you have pain, drainage, or sudden hearing changes at any point, seek care immediately. An uncommon question is, if professional removal happens, will the ringing go away? The honest answer is sometimes, and sometimes not entirely. If the cause of tinnitus is conductive, meaning related to how sound reaches the inner ear, removing the obstruction can reduce or eliminate the ringing. But if the tinnitus stems from inner ear hair cell damage, prolonged noise exposure, or other non-conductive causes, removing wax may not resolve the sound. That's why a thorough evaluation by an ENT or audiologist is important when tinnitus is persistent. If you make it this far in the reset and you're already feeling different, that's a good signal. Many people find that simply stopping the swab habit prevents further compaction and reduces the risk of new problems. For others, surviving the week without a swab exposes a lingering issue that needs clinical attention. In both cases, you've moved from reactive scratching to deliberate, safer care. There are situations where home measures are not appropriate. If you have diabetes, a compromised immune system, a history of ear surgery, or a known perforated eardrum, do not use cerumen softening drops or attempt any form of home removal without clinician clearance. These conditions raise the risk of infection or complications. Instead, see your primary care doctor or an ENT for safe, supervised care. When you do see a clinician, what might they do? They may examine your ear with a microscope to directly visualize the canal and eardrum. If significant impaction exists, gentle professional removal techniques like microsuction or instrument-assisted extraction may be performed. These are done under direct visualization to minimize risk.
Occasionally, clinicians use irrigation, but only after confirming that the eardrum is intact and there's no contraindication. The point here is that professional approaches prioritize visualization and safety. They are not the same as forceful do-it-yourself methods people sometimes try at home. As you weigh the option of seeing a professional, remember the safety signals. Severe pain, bloody or smelly discharge, sudden hearing loss, or a marked increase in tinnitus loudness are reasons to seek care promptly. If your symptoms are mild, you can continue the reset and monitor for change, but be ready to escalate if needed. At this point in your week, you may be feeling a mixture of relief, curiosity, and perhaps some anxiety. Habit change is rarely linear.
You might have days where the urge returns strong. That's normal. Keep practicing the 90-second interruption. Use alternative microactions like the tragus massage, and continue diligent outer ear drying. If you're someone who has used cotton swabs for decades, the psychological comfort they provide can be as hard to replace as the physical habit. That's why this reset includes a journaling component, not to make you obsessive, but to provide objective data you can show your clinician if you need one. There are practical tweaks that help make the new habit stick. Replace visible cotton swabs in your bathrooms and nightstands with a small box of tissues or cotton balls stored out of sight. Leave a sticky note on your bathroom mirror for the first week, reminding you, no objects in ear canal. Pair the new ear care routine with an existing cue, like after brushing teeth. Dry the outer ear, check for symptoms, and log. Celebrate small wins. Each day you avoid swabbing, you reduce the chance of creating new compaction or damaging the delicate skin inside the canal. If you're a parent, use the reset model for your household environment. Remove cotton swabs from reach, use a soft cloth for visible outer ear cleaning, and teach children that ears are self-cleaning. If a child complains of persistent ear pain, fever, or hearing changes, see a pediatrician quickly. Children can develop ear infections or other issues that need prompt treatment. By now, you should have a practical sense of why cotton swabs do more harm than good, what safer immediate actions look like, and how a structured week of behavior change can reduce risk and provide clarity. You've also created a data trail, journal entries, symptom ratings, and environmental changes, which are valuable if you end up consulting a clinician. Many people ask whether small, occasional use of swabs is harmless. The honest response is that occasional, very careful cleaning of visible outer earwax with a tissue is low risk. The harm tends to happen when swabs are used routinely and inserted deeply, or when they become the first reflex to any itch or minor sensation. Repeated probing increases the likelihood of compaction, fiber retention, and skin trauma. If you're thinking about the next steps, scheduling an ENT, trying serum and softening drops, or continuing the reset for a month, use your week's notes to guide that decision. If your symptoms improved and no red flags appeared, continuing your safer routine and monitoring makes sense. If nothing improved or symptoms worsened, make an appointment and bring your symptom log. Clinicians appreciate precise descriptions. When did the ringing start? What makes it better or worse? Any recent noise exposure, medication changes, or head or neck issues like jaw pain? Those details help narrow down causes beyond impaction. Imagine now a patient named Daniel. He's in his mid-40s, a weekend drummer who had used swabs since childhood. He started noticing intermittent ringing after a particularly loud music festival. He assumed it would fade. After a month, the noise was still there, and he had a persistent feeling of fullness in one ear. He tried the 7-day reset and noticed no improvement in the fullness, though his urge to swab decreased. He scheduled an ENT appointment. The ENT found moderate wax impaction and also signs consistent with noise-related inner ear changes. The plug was removed professionally, his fullness improved, and some of the ringing decreased, but he continued to have a low-level tinnitus that was likely related to noise exposure. For Daniel, removing the compaction helped but did not erase all causes of tinnitus. He then began a protective program, limiting exposure to loud environments, using ear protection at gigs, and working with an audiologist on sound therapy strategies to reduce the perceived loudness of his tinnitus. Stories like Maya's and Daniel's underscore the mixed reality. Sometimes compaction is the main problem and removing it brings relief. Sometimes it's one of several contributing factors. The safe, sensible path is to reduce behaviors that can cause compaction, monitor symptoms objectively, and see a clinician when needed. As you head into the second half of your behavioral scaffold, there are additional layers we'll cover: a deeper troubleshooting FAQ that anticipates common concerns, a step-by-step guide to what to expect at an ENT visit, and clear red flag language so you know when to seek urgent care. We'll also unpack safer long-term habits to prevent relapse and explore how to manage persistent tinnitus if it doesn't resolve after removing any compaction. For now, take stock of your week. Review your journal entries. If you've already noticed less urge to probe and no red flags, you're moving in the right direction. If you still feel blocked or worried, getting a professional look is reasonable and often reassuring. Either way, you've reduced the immediate risk of further compaction by stopping the swabs, and that alone lowers the odds of creating a bigger problem. Keep the ear safety checklist nearby as a practical reference through the next steps, and remember, the goal is safer, sustainable habits, not instant perfection. Finish the week strong and be prepared to act if symptoms persist or get worse.
If you've kept the habit reset going through the week, the next step is troubleshooting with care and clarity, and preparing for what comes if a clinical visit is needed. When you decide to see an ENT or audiologist, having clear, objective notes makes their job easier and speeds up the path to the right intervention.
Bring your mini journal or a concise timeline. When the symptoms started, any recent events that preceded them, loud noise exposure, head and neck strain, new medication, swim in unfamiliar water, how the sensation has evolved, what provokes or relieves it, and your simple daily scores for fullness, ringing, and hearing clarity. Those few lines of data are powerful. They let the clinician separate a transient annoyance from a pattern that needs investigation. What will an ENT likely do during the visit? Expect 3 practical low-friction steps. First, a careful visual inspection of the ear canal and eardrum with a lighted magnifier or microscope. That lets them detect visible wax, foreign material, inflammation, or a perforation. Second, a basic hearing check and possibly tympanometry, a non-invasive test that assesses how the eardrum moves if there are signs of conductive change. Third, a targeted conversation, questions about your noise history, medications, overall health, and any head, neck, or jaw issues. If the clinician suspects impaction, they'll discuss options for safe removal. If the problem seems to originate deeper in the inner ear or central pathways, they may order or recommend audiometry or refer you to an audiologist. It's useful to understand, in plain terms, the common professional approaches to removing cerumen or foreign material and their safety considerations. Microsuction is one technique many clinics use. Under direct visualization, suction gently lifts the wax or material out of the canal. It's done with fine instruments and a steady view of the ear, which reduces the risk of accidental contact with the eardrum. Instrument-assisted extraction, using small specialized tools, is another option, but it is performed only when the clinician can see clearly and judge it safe. Irrigation, or professional flushing of the canal, is sometimes used, but only when the eardrum is intact and there are no contraindications. These are clinician-led procedures. The key difference between professional removal and most home attempts is visualization and control. An ENT can see what they're doing and stop if the ear's anatomy or the patient's history makes a method unsafe. Now, let's unpack a deeper troubleshooting FAQ that addresses the questions people call their doctor about most often, with clear, cautious answers you can use as a mental checklist. Can occasional cotton swab use be harmless? The occasional very superficial wipe of the visible outer ear with a tissue or corner of a towel is low risk. The problem is habitual deep insertion and reflexive probing. Over time, repeated penetration increases the odds of pushing material inward, leaving fibers behind, or abrading the delicate skin. Habitual use is what becomes problematic, not a single careful outer wipe. If I stop swabbing, how long before symptoms improve? There's no single answer. Stopping the habit prevents further compaction and damage, which is immediately protective. If the issue is recent and minimal, some people notice subjective relief in days to weeks. If compacted wax or retained fibers are already lodged deep in the canal, professional removal is often required. Stopping swabbing alone won't dislodge that material safely. Use your symptom log to identify trends, rather than expecting an instant cure. Is ear candling safe or effective? Ear candling has not been shown to safely remove wax and carries clear risks: burns, hot wax entering the ear, and even pushing soot or residue into the canal. Major medical groups discourage it. Avoid it. Are over-the-counter wax drops safe? Some clinicians recommend cerumen softening drops for people with mild, non-painful buildup and no history of eardrum perforation, recent surgery, or immune compromise. If you consider drops, follow the product instructions and stop immediately if you experience pain, discharge, or increased ringing. If you're unsure whether drops are appropriate for you, ask a clinician before using them. Can cotton fibers really harden? Cotton fibers themselves don't harden like a rock, but they can entangle with cerumen and skin debris. In a confined, less oxygenated environment like the ear canal, that entangled mass can dry, compact, and adhere more firmly to the canal wall or eardrum. The result is a mass that feels firmer and less likely to shift with jaw motion, and it can produce pressure sensations or altered conduction of sound. Could my tinnitus be permanent? Tinnitus is a symptom, not a diagnosis. If tinnitus arises from conductive issues, such as a compacted plug altering how sound reaches the inner ear, removing the obstruction may reduce or eliminate the symptom for some people. If tinnitus reflects inner ear hair cell damage, noise exposure, or other non-conductive causes, it may persist. Persistent tinnitus can often be managed so it's less intrusive, even when it can't be completely eliminated. Management options are individualized and might include sound-based strategies, counseling approaches, and lifestyle adjustments administered with a clinician or audiologist. Is home irrigation ever safe? Home irrigation is riskier than many people expect. If you have a known eardrum hole, recent ear surgery, recurrent infections, diabetes, or immune suppression, irrigation can cause harm. Even when none of those apply, incorrect technique or pressure can injure the eardrum. If you're considering irrigation because of significant blockage, a clinician can determine whether it's safe and perform it under visualization or offer alternative removal methods.
If you decide to schedule a clinic visit, a few practical tips will make it more productive. Bring your symptom log and note the dates and situations that seem relevant. For example, a particularly loud concert 2 weeks before symptoms started.
List all current medications, including over-the-counter supplements. Tell the clinician about ear-related medical history, past perforations, surgeries, chronic infections, or use of hearing aids. If you've used any home remedies, be honest about them. It helps the clinician judge safety and next steps. Finally, ask what to expect during removal and how to manage your ears afterward to prevent recurrence. Let's shift to prevention and long-term relapse strategies. Old habits tend to return when the cues and rewards that formed them remain in the environment. Your aim is to rewire both the physical environment and the automatic reward, so the new behavior is easier than the old one. Start by changing the cues. Put cotton swabs somewhere you don't see them every day. Keep tissues and a soft towel in plain sight instead. Put a sticky note on your bathroom mirror for the first month. A simple reminder reduces slips. Pair the new routine with an established habit. After brushing your teeth, dry your outer ear while your music plays for 30 seconds. Use a visual or physical anchor, a small shelf object or a different soap bottle that serves as a nudge to perform the safer behavior. Over time, the alternative action should become the path of least resistance. Work on the reward. People swab because it feels satisfying. Replace that instant reward with something else pleasant but harmless. After you complete the 90-second pause or the gentle tragus massage, give yourself a quick positive reinforcement, a micro break, a sip of water, or a check mark on your progress sheet. Doing this repeatedly conditions your brain to associate the alternative act with satisfaction. Manage relapse triggers. Stress, fatigue, allergy flare-ups, and high-risk contexts, like lying in bed at night, can reactivate the habit. When you know a trigger is coming, after a long travel day, during allergy season, or following a loud event, plan a coping response in advance. That might be a one-off extra rehearsal of the visualization technique, keeping ear protection on hand after a concert, or asking a partner to help remind you to avoid inserting objects. For long-term prevention, think in layers: environmental control, out of sight, out of reach, anchor routines, pairing with daily habits, micro-interruptions, 90-second pause, and alternative tactile feedback, tragus massage, outer ear towel dry. Together, these create redundancy. If one layer fails, others still protect you. Now, let's address managing persistent tinnitus if it doesn't resolve with wax removal or behavior change. First, recognize the psychological impact. Persistent ringing can be upsetting, anxiety-provoking, and sleep-disrupting. The most effective management plans treat both the perceptual and emotional components, and they are tailored by professionals. One strategy commonly used in clinics is sound enrichment. The idea is simple. Provide a comfortable, non-intrusive background sound to decrease the contrast between silence and the tinnitus. This might be ambient noise from a fan, soft music, or a low-level sound generator provided by an audiologist. Sound enrichment doesn't mask the tinnitus permanently. Instead, it changes how your brain focuses on the internal noise. Audiologists can guide you in choosing sounds and volumes that are calming and sustainable. Avoid turning up sound levels aggressively. The goal is comfort and habituation, not loud masking. Cognitive approaches can also be helpful. Cognitive behavioral strategies for tinnitus focus on changing the negative thoughts and emotional responses that amplify distress. Working with a trained therapist or clinician can help reframe catastrophic thinking and improve coping. Some people find mindfulness or relaxation techniques useful. These approaches do not remove the sound, but they can reduce reactivity and improve sleep and mood. Hearing technology can play a role when hearing loss accompanies tinnitus. Amplifying environmental sound safely through hearing aids can reduce the perceived loudness of tinnitus in some people by restoring a fuller soundscape. This is assessed and fitted by an audiologist. It's not a one-size-fits-all solution and requires professional tailoring. There are community and self-help options that can support coping without harm. Peer support groups, whether in person or online, can reduce isolation and provide practical tips. Educational materials from reputable clinics and professional organizations can explain management options in understandable language. Again, caution is wise. Online forums can offer helpful empathy, but may also circulate unproven remedies. Use trustworthy sources and consult clinicians to vet any proposed interventions.
Let's talk briefly about occupational and lifestyle measures that protect your ears and reduce future risk. Noise exposure is a leading preventable cause of hearing damage and tinnitus. When you know you'll be in a loud environment, concerts, construction sites, even noisy gyms, use appropriate hearing protection. Foam earplugs are inexpensive and effective for many situations. Reusable silicone plugs and well-fitting earmuffs are alternatives. For frequent or professional exposure, consider custom-fit earplugs made by an audiologist. They provide comfort and consistent protection. The principle is simple. Lower the intensity of sound reaching the inner ear, and you reduce the chance of creating new auditory damage. Bedroom and sleep hygiene are relevant too. Many people report tinnitus intruding at night when external sound levels drop. A low-level sound enrichment device placed on a bedside table can help smooth transitions to sleep. Addressing insomnia, anxiety, and caffeine or alcohol use in your bedtime may reduce the subjective impact of tinnitus.
Be mindful of stimulants. In some individuals, high caffeine intake or disrupted sleep seems to worsen sensitivity to internal sounds. These are individualized effects. If you notice a pattern, modify your habits and observe whether the sound becomes less intrusive. Jaw and neck health deserve a quick mention. Temporomandibular joint (TMJ) dysfunction and neck muscle tension can sometimes coincide with ear sensations or tinnitus. If you have jaw pain, teeth clenching, or neck stiffness, mention that to your clinician. A multidisciplinary approach involving dental professionals, physical therapists, or clinicians experienced in TMJ disorders can be appropriate when these factors are present. Now, practical advice for parents and caregivers that goes beyond don't use swabs. Model the behavior. Remove swabs from family bathrooms and explain to children in age-appropriate terms that ears clean themselves. Use supervised, gentle outer ear wiping for visible dirt. If a child complains of ear pain, fever, or sudden hearing change, see a pediatrician promptly. Ear infections and other childhood ear problems can require early treatment. Never try deep cleaning for a child at home. There are also useful technology and app tools to support habit change without encouraging hypermonitoring. Simple apps for journaling or symptom tracking can make your lobs tidy and shareable with clinicians. Some tinnitus management apps offer sound libraries for enrichment. If you use these, choose options that emphasize low-volume, comfortable sounds and avoid aggressive masking. The goal is habituation and reduced distress, not drowning out the symptom at unsafe volumes. Let's return to the psychological element, because habit change is often more about the mind than the ear. If swabbing has been your go-to stress reliever, find a substitute that satisfies the same urge. Hand fidgets, a stress ball, short breathing exercises, or a 5-second grounding routine can fill that space. The 90-second pause is a crude but effective cognitive interruption. Over time, try to reduce the pause length as your new automatic response strengthens. Reward systems help. A simple habit streak calendar or a small weekly treat reinforces consistency without creating guilt over slips. If you bump up against persistent anxiety about your ears, constant checking, obsessive listening, or panic when you feel a slight change, consider brief counseling. Anxiety amplifies perception. Addressing it not only improves quality of life, but also reduces the frequency of actions that could cause ear trauma. A few more troubleshooting questions people often have. What if I feel like something is still stuck after removal? Sometimes people sense residual fullness after a clinician removes wax. That can reflect temporary ear canal or middle ear irritation, transient changes in pressure, or inner ear sensitivity that the brain interprets as fullness.
If subjective symptoms persist beyond a short recovery period, follow up with your ENT. They may recommend audiometry or a recheck to ensure no underlying issue remains. Should I avoid swimming? You don't have to give up swimming because you're worried about ear problems, but take precautions. Use fitted earplugs if you've had recurrent infections or chronic perforation, and follow careful drying afterward by tilting and gently towel drying the outer ear. If you notice pain or discharge after swimming, see a clinician promptly. What about medications that list tinnitus as a side effect? Certain medications are associated with tinnitus in some people. If you started a new medication around the time your symptoms began, tell your clinician. They can evaluate whether a medication could be contributing and whether any safe adjustments or monitoring are appropriate. Do not stop prescription medications on your own without clinician guidance. How do I choose the right clinician? Start with an ENT for ear-specific concerns and visible symptoms like pain, discharge, sudden hearing loss, or suspected perforation. For persistent tinnitus without clear conductive causes, an audiologist is a key partner for assessment and management. For complex cases that involve pain, jaw issues, or systemic conditions, multidisciplinary care, ENT, audiology, dentistry, and sometimes mental health provides the broad view you may need. Finally, practical expectations for the days after clinical removal. You may experience a brief period of increased awareness in the treated ear as your auditory system reacclimates. Sounds can seem strange for 24 to 72 hours. Mild irritation or temporary increased tinnitus is possible, but usually settles. Follow any aftercare instructions your clinician provides. Avoid aggressive water exposure for a short period if advised, keep follow-up appointments, and report any worsening immediately. In closing, the core actions remain simple and achievable. You have already taken a major step by stopping the automatic insertion of objects into your ear canal. That alone lowers the risk of making a small issue worse. Continue the habit replacement strategies, environmental changes, anchor routines, the 90-second pause, and gentle outer ear care. Use your symptom log to track trends, not to fuel anxiety. If you experience severe pain, bleeding, smelly discharge, sudden hearing loss, or persistent or worsening tinnitus, see an ENT or audiologist promptly for evaluation. Professional assessment can identify whether impaction is present, and if so, remove it safely. It can also help discover other causes of tinnitus and guide management so your symptoms become more manageable. Take care of your ears the way you would any sensitive, self-regulating system. Avoid invasive shortcuts, choose protective routines, and seek professional help when signs suggest escalation. If you followed the reset and still have concerning symptoms, arrange a clinic visit and bring your log. It will make the conversation clearer and your care more efficient. If persistent ringing, pain, discharge, or hearing change is affecting you, see an ENT or audiologist for evaluation.